Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Tim Gronniger from Hopscotch Primary Care about expanding the frontier, the future of primary care. Let's get started. Hello, Dr. Dan.
Hey, Faisel. How are you today?
Good to see you, and I'm excited about our conversation today. We've got a special guest. Tim Gronniger, welcome.
I am very happy to be here. Yes, good afternoon. Thank you for having me.
We were just talking. You have quite an impressive background from CMS all the way to the White House. And what was the tipping point that made you want to get into primary care with Hopscotch?
Yeah, I've been working on various parts of the value-based care journey over the last 20 years. I was a policy geek, technician. I really was fascinated by the way that how Medicare paid for services, goods and services affected the delivery of care, and as you've covered extensively, can distort incentives, not just in primary care, but can lead to substandard, suboptimal care that's not built around long-term relationships, but that's more transactional just by virtue of needing to keep the lights on in any given practice or any given service line. I was fascinated with that and spent a lot of time during the early days, the pre-Affordable Care Act days, studying that, building economic models around that. Started on the Hill, the Congressional Budget Office, jumped over to the policymaking teams on the Hill during the Affordable Care Act, and with the portfolio of payment reform, accountable care organizations, the Innovation Center. Saw that through implementation days in the White House and in CMS. Got to know brilliant people, brilliant mentors with administrative leadership at CMS during the tail end of the Obama administration, and got the bug of wanting to take this out into the so-called real world and make it happen, right? And so admired what some early leaders like the Chens had done and what Farzad was doing at Aledade. Found a company called Caravan Health that was more originated in the West, central part of the country, working with rural hospitals and their affiliated physician groups, their affiliated clinicians, building value-based care models, bringing them technology, bringing them wraparound services, helping them build new business models, as Don Berwick called it, supporting the business case for quality, right? My job in the government and outside of the government, I'm not a physician. I appreciate you having a non-physician on occasionally. I know you do a great job rotating some incredible physician leaders through this group, through this podcast. My job as a non-physician is to solve problems, right? And to make it easier. Nothing's easy in primary care and family medicine, but to the extent that we can even have the existence of these economic models and these contractual arrangements that allow for longitudinal relationships that are based on outcomes that are aligned with what patients care about and what purchasers care about is an incredible privilege. So Caravan Health for 6 years, incredible experiences there. I learned a lot and joined up with Hopscotch 6 months ago. So I'm new on the gig, but we are serving small towns and rural markets right now in Western North Carolina, bringing an intensive primary care model to areas that have just massive access needs, right? We serve areas with very difficult drive times, very limited access, very stretched panels for existing practices and hospitals in the area. So it's an awesome company. I'm privileged to join the team recently, and I'm happy to talk about the value-based care journey and anything that you're interested in with Hopscotch today.
Faisel and I both grew up in rural areas, and the vast majority of my professional practice has been in rural areas, except for my 7-year sabbatical to ChenMed. I've always thought it would be the risk model and the ability to bring resources to bear in rural areas would be pretty cool, but recruiting doctors in rural areas is pretty tough. So what do you view as similar and different in rural areas versus urban areas working in this value-based care world? Because you seem to have had a lot of experience doing it first at Caravan and now with Hopscotch.
It's such a great question, and it's interesting to look and compare and contrast. And as we grew at Caravan, we started in rural and grew to serve more middle market hospitals, and then worked with some very large systems by the end. And so I've sort of seen it in all scenarios. And you're exactly right. Like what works in urban and what, the ChenMeds and Oak Streets and others have been really successful with, say, variety varieties of transportation services, right? Where you can pick up patients, get them in that otherwise wouldn't. That the math on that is just dramatically harder in rural areas where patients routinely drive 25, 30 minutes to a clinic, and sometimes more if they don't have close access. You have to have really good targeting in services like that. On the flip side, some of the problems that we see in rural areas and some of the very real health disparities, much higher risk of a variety of life-limiting, life-affecting conditions, whether it's cardiovascular disease, smoking-related cancers, and respiratory diseases in our part of the country. You flip these around and there's more economic justification for investing in interventions that will affect these outcomes. That's one strength of serving rural areas. The strength of the teams is something that has consistently blown me away. So we are able to recruit and create a work environment that is just very favorable, very pleasant. We've recruited phlebotomists who rotated through our clinics who said, this is the first place where anyone has said hi to me or asked me how my day was going. So you're able to really cultivate a strong culture where people know each other, people know the patients. Everyone on the team is contributing to the patient engagement in the clinic, and the welcome coordinators know the patients very well. They're able to track them down, keep them engaged. So there are pieces of strength here, and I think now further along in the journey and in the enablement vendors in value-based care. So there's far more access to virtual specialty partners than there ever was before. There's far more access to engagement technologies, and now with more AI solutions coming online, there's much more ability to leverage provider time and overcome some of the geographic barriers. So it's a great time to be working on these problems in this type of risk model.
I mean, you're working in a space that's really close to both of our hearts over here, especially with what you're doing in rural America. So in the last 6 months, I mean, me too. I've just started at City Block. I'm at City Block Health now, working primarily with Medicaid population between Tampa and Orlando. And that's something that comes up quite frequently. As soon as you move just a few miles outside of Tampa or Orlando, I mean, you could just very well feel like you're 100 miles away from anything. What has been your biggest learning experience over the last few months there?
I think that understanding the markets and the populations we serve, it is a hyper-local experience. And just as you describe, you both grew up in rural areas. I grew up in a suburban area, and my father grew up in a small town, right? And you can begin to see the modes of engagement and the type of clinic that you need to run to succeed in these different types of places. If I'm in Olathe, Kansas, where I grew up, which is a suburb 25 minutes outside of Kansas City, very different type of clinic than you can run in Atchison, Kansas, which is where my father grew up, which is a small sort of farm distributor commerce, small town, 20,000 people. And so driving around Western North Carolina, meeting our teams, understanding what they're able to do and how they're able to bring their knowledge of local resources, knowing who to call, whether it's with the county government and accessing transportation when it's available, knowing who to call with the various payers locally, the wealth of capability and relationships that can be brought to bear on improving the patient experience is not something that I anticipated coming in, but it's a huge asset for us that we're working on developing further.
When did you start with Hopscotch? Was it before or after the hurricane? I guess because I'm sure everybody there probably dates everything to whether it was before or after the storm. What was that like coming in? Because surely a lot of the staff and certainly a lot of the patients are probably still traumatized by what happened by that.
Yeah, you're exactly right. Coming in 2 weeks after it happened, I was just so impressed by the response that I saw certainly from our teams, and both the local clinic teams that were in some cases reopening their clinics within 2 days of the storm hitting. For those that haven't been in the area, that don't know people locally, the impact of the storm on that area was shockingly large and severe. The displacement was so widespread across an area hundreds of square miles large. It was just a massively harmful event, and it's still, the area hasn't recovered, and there are places that still don't have access through regular roads and transport. Many or even most of the smaller bridges serving small roads are still not repaired. A number of our team members in some of our most severely hit areas around Spruce Pine and Burnsville actually lost their homes. There was really tragedy everywhere. Through it all, our teams were engaged and dying to come back to work and wanting to to serve their patients. We had teams that spun up and reached out to virtually all of our patients that we could reach over the weekend, the first weekend of that storm impact. So that you really do see the value of this type of data-informed, highly connective primary care model in those scenarios. But there's no planning. This isn't something that you plan or that you have like playbooks for. Teams were resilient locally. We supported them as best we could from our corporate perspective, and had a number of support initiatives and a little bit of fundraising to go along with it. But it was really an impressive response from our local clinic leadership and from everybody on each of those individual clinics.
And I think that brings up an important point about the importance of primary care in areas and having access to it. It can't. Well, I think we're all very big proponents of technology and being able to do virtual care. That's a great extender of care. It's still important to have those people that are local and able to respond in times of need. And it just having those relationships make a huge difference to people when that happens.
There's no doubt about it. And there's no substitute for physical presence in actually having a clinic. There's plenty of debates, enablement, virtual care, but at the end of the day, there's no substitute for having actual physical presence where patients can come and see you. There is still a large number of patients that really prefer to be seen in person. You can dispense medicines during an emergency. A number of our offices were sort of distribution hubs for supplies locally, and we're supporting emergency response efforts, not just for Hopscotch patients, but coordinating with county and state emergency responders. So yeah, it's that. And then we also have a very strong local market team, one of whom is Dr. Dan, former Navy submariner, just an incredible operator who has a really strong team supporting him, able to sort of share resources across clinics, bring in support from outside that region where possible. So yeah, the value of this approach can shine through in times of real emergency as well.
And this is why we got to make primary care the foundation of the entire healthcare system. I mean, people are chomping at the bit to get back to work. It's a calling. That's why your staff, and we saw here down in Florida with the hurricane, similar response. Just people on the day of wanting to get out and help. It's amazing.
It's not just during disasters either, right? It's the day-to-day work of primary care. This is, very cliched, but we hear it from our teams. And what I'm trying to build is an economic structure and a practice management infrastructure that is the sort of the new generation of independent primary care practices, right? So there's been a lot of tears spilt over the decline of independent practice, and there's a lot of reasons to shed those tears over the decline. But I think the modern version and what our vision is that we can support independent practices that are independent in the sense of you as a medical director are responsible for the care and outcomes of your patients. You're responsible for managing the people in your clinic, the team members. You're responsible for outcomes, and you have a good motivating work day and work week and work month that produces good clinical and financial outcomes if you do well. But we as Hopscotch will bring you a very strong enablement platform that will help you do the hard part, take as much of the administrative burden off of you as possible, handle HR, handle IT, handle contracting. This is a new model. I think that we're standing on the shoulders of giants, and we've learned a lot from those who have gone before us in these risk-based primary care models. But we're able to use newer technology. We're able to use everything that we've learned. We were spun out of Oak Street Health originally, but an idea and incubated just a few years ago. So we're able to sort of phone a friend, not just, we have people who've worked at ChenMed, we have people who have worked at Iora, many people who have worked at Oak Street Health. So we were able to apply those playbooks, the well-understood Medicare and other advanced primary care playbooks to a new environment, to a new area, and to create, ideally, this is always a work in progress, right? We're never in a situation, and if you polled all of our providers and physicians, you wouldn't get 100% satisfaction. I would love to get to a point where you do. My desire is to get to a place where this is a really engaging, a really attractive place to work for physicians of all parts of their career spectrum.
Part of the issue when you start working in these models is when you're in the fee-for-service world, the payers treat the information as proprietary. You really don't get the full 360-degree picture of what's going on with your patients. But now, when you're in the full risk model, you're getting that data, and now you're seeing so much more of what's going on. And when you're taking accountability for that, I think in a lot of models, doctors have been able to pat themselves on the back and say, yeah, I'm doing a good job. They're paying me for my RVUs, and I'm doing all compliance requires of me. But it's a whole nother thing to build a relationship with the patients and get them, influence them to make the changes they need to make. And I would imagine, I don't know, but I would imagine that's something that your doctors may at times struggle with, right? You're no longer in Lake Wobegon where everybody's above average. And so now you've got to look at what you're doing and figure out what you can do differently.
It's such a good insight, and it really gets down to, I've got a couple of responses to that actually. One just in the day-to-day management, you're exactly right. And it's such a, none of us grow up, probably most of us on this video call receive pretty good grades in school. But you have to learn as you go into the working world, like how to accept feedback and how to recognize where we're not going to be straight A's all the time, and we got to work on the areas where we're starting off at a C, right, and get it up to ideally an A, but maybe a B plus for the next year, right? So that's not something that they teach in med school. It's not something that comes easy to a lot of us, and we're trying to really cultivate those leadership skills among our clinic medical directors to embrace that mentality, because it's so important to, when you're managing not just your own panel, but when you're supporting the management of the panel of other members of your team, and when you're managing individuals on your team who aren't physicians. That's just such an important mindset. I will also say, you remind me that the availability of data in value-based care models, I always get laughs out of the youngsters in the industry when I remind people that it wasn't 15 years ago that Medicare data was considered a proprietary government asset that wasn't to be shared with physicians and caregivers. It was a massive fight to get claims data widely shared and widely liquidly available. And folks like Todd Park and Niall Brennan and a whole bunch of others over the years did a lot to push that data out. But it's absolutely central to the ability to manage patients effectively over time. And we're very lucky to have not just that access to that data, but access to a whole ecosystem of analytics and other companies and toolkits that allow us to use it effectively.
I love how you're putting this all together. I just wish some of the policymakers, I hope some policymakers they're still so focused on the hospital-based model. I feel like we can get most of the policymakers to agree, hey, primary care is the right thing to do. How can we convince some of these policymakers that this is the smart thing to do for the healthcare delivery system?
Yeah, I mean, there's the sort of strategic level considerations, or just like some of this gets to how do you view progress over the last 15 years, and then there's the tactical level of what specific policy levers you can pull. I end up being a lot more optimistic about the progress over the last 15 years. I look back over the history, and like we were just talking about, data to support care management and quality improvement basically didn't exist on a patient level. The ecosystem of analytics, products, and toolkits didn't exist. There was the proof of concepts that managed care, sort of lowercase managed care could work, was basically Kaiser and one or two quirky physician groups in the upper Midwest and Pennsylvania. So it was like, could this be spread nationally was an open question. Could EMRs be adopted was an open question. These were the hard fought policy battles, right? It's easy to forget, but we people complain about EMRs, and they're annoying elements of the healthcare economic incentives that drive why EMRs are administratively complicated. But no one's going back. No one, the physicians who said they were going to retire before using them, many of them did. Some of them converted and changed their minds, right? So progress has happened. Progress is still possible. And I think that the hard things in healthcare, many of them live outside of our world of primary care, value-based care. I think that we have a number of very successful examples of successes in advanced primary care in Medicare over the last 10 years. And so to me, the technical question is how do we spread them further and to get from, call it between 5 and 10% adoption of successful advanced primary care outside of Medicare Advantage, and grow them both within the parts of Medicare Advantage that aren't in these advanced primary care models, and then grow them within original Medicare as well. And that's part of the mission at Hopscotch, right? The rural areas, small towns are very underserved by advanced primary care. So we are working on this problem. If I was in my old jobs at CMS or on the Hill, I think that gets you to questions of, well, how do we want to start to take this apart into bite-sized problems, while you're also worrying about sort of global glacial or tectonic plates of, well, we're consistently falling behind on inflation-based measures of physician rates, on hospital reimbursement rates. They have complicated decisions to make about Medicare Advantage. So I'm sympathetic to the set of challenges that they are dealing with here. But I do think that we are in a position now where we know what works, and it's a matter of extending that, not just within Medicare, but figuring out ways to pay for advanced primary care and other parts of the healthcare system that make sense. And City Block, Dr. Faisel, is absolutely one of those places that is figuring it out in Medicaid. I'm a big fan of the company and toy in.
The access is even today I had to help. There was a patient didn't have a phone, but we had there was a community case manager at the homeless shelter who is our point of contact for him. And I found out he was going to the emergency room. Do you know he's going to the emergency room once every month for lisinopril, atorvastatin, and a baby aspirin refill? And they were giving him 30 days supply at a time. Unbelievable.
Wow.
Unbelievable. And so the only way we could do a visit with him was to send a paramedic to his home. We have paramedics to send a paramedic to the shelter and then do a video visit with the paramedics technology. So I would love to hear about, we're big fans of the team-based approach in general. So I would love to hear a story, like a patient story, with how your team came together to help someone who's living away from what we're used to seeing in urban and suburban America.
It's so interesting and it's so rewarding that we see these patient stories and patient testimonials come in on a daily, weekly basis that are just life-changing stories, right? And it's such an intensive model, and we have such incredible face time. Like the patients that we're seeing are in many cases just shocked that a model like this exists and that we've come to their town. We get thanks that are like, "Thank you for being here. This is the best thing that's happened to this county for seniors in the last 30 years." Quite comments like that, right? So a lot of the best stories, the stories that I like that I've noticed lately, they really get back down to the essence of what primary care is. Like we had an individual come through recently who was disengaged from care. So many of our patients in this area are disengaged from care for a million reasons: social factors, drive time, stretched practice panels at their existing incumbent family practices, and so you get the initial reaction of like, well, why do you want me to come in? Sort of skepticism of like, is this some sort of trick? Are you trying to bill me extra for this? And then it's like, okay, you start to establish trust. And so this individual, his wife was a Hopscotch patient who asked him to come in, very resistant to engaging with the care team, and described to us pain he was having in his knee. He could barely walk. Spent a good amount of time with, and this is one of our practices, led by an individual who's a former an alum of Navy medicine, a very sharp nurse practitioner. Sat down, spent extra time with this patient. This is very much the value of where you can afford to finance extra time with patients who need it, and that's such a rare thing, and that's why this type of economic structure is so important. Spent time with this guy, got him to talk it out, understood that the knee was really the source of all of his problems, and set him up for for very straightforward cortisol injection in the knee. Sent him home. We're going to follow up with him virtually a couple weeks later. But he walked back into the office 2 days later, happy as a clam. Hadn't felt better in his, he said in 10 years, and has stayed engaged with us throughout. And so a number of patients that come in that have sort of the classic metabolic cluster, diabetes, hypertension patient we were talking about on one of our all hands last week of 71-year-old woman who had brain fog, was really struggling with her meds. And this was a situation where she was taking, she didn't, understand her medicine. She was definitely on meds that had overlapping indications. And so our team spent time with her and deprescribed a couple of the meds, cleared up not just her brain fog, but also improved measures on her blood sugar, and she felt just dramatically better within a relatively short period of time. So stories that really show the value of, sometimes you got to do a 40-minute visit, and then you got to do another one the week after, but you can really create life-altering changes for patients in those settings.
Yeah, and it really does. I think when you work in that for a while, you start looking at what else is out there, right? And not just Faisel. You talk about there's the chief complaint, and then there's the doctor's primary concern. So the chief complaint might be somebody coming in complaining coming in for the flu, and they've got but they're not hypoxic or anything. But then you realize there's a smoker, and so their chief complaint is the flu. The doctor's primary concern is, how do I work with them to get them to cut back on smoking over time, because they're going to keep having these respiratory illnesses until we figure out how to intervene for some of their other complications. So, but the relationship makes a huge difference. I mean, so the guy who got his knee injected, he'd probably take off his clothes and run through the parking lot naked if you told him he would feel better after that, right? The doctor made him feel so good, he will do whatever they ask him to do to feel better next time.
I mean, I'm not going to endorse that, certainly, but from your lips to God's ear. But you're exactly right. Like, just imagine the difference in the daily experience of, you can barely walk and you're in constant pain, and then you're not. It is life-changing.
There's a mindset shift in value-based care. We use the chief complaint for us as our opportunity to earn trust. And then once we get chummy, oh, hey, can we talk about this?
What are your final thoughts for physicians or residents considering primary care in general and in rural practice in particular? What suggestions do you have for them?
It's such rewarding work. I think that there are pockets of true excellence that you can find. And I know we continue to have a primary care supply problem. I think that, for me, as an economically oriented, problem-solving individual, I think that continuously improving the structures and the processes that we can put behind primary care, building successful primary care practices, paying well for good work, for good outcomes it's possible. It's happening out there. We're doing it at Hopscotch. Others are doing it well as well. We are recruiting. We are absolutely happy to recruit from all over the country. And I know that others are as well. There are really satisfying ways to orient your practice and your careers in fulfilling longitudinal, patient-focused relationships that can be just tremendously rewarding. So if this is something that is appealing to you, there are places where you can do it and practice some of the really old-fashioned virtues of medicine, and that's what I aspire to create at Hopscotch with the way we help manage and support our clinics.
Thank you so much, Tim, for joining us today. That was an excellent conversation.
Thanks so much for having me. That was really fun.
What are your thoughts on expanding the frontier, the future of primary care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.